you've seen. Most notably, you won't see the typical multi-panel Brady Bunch view. Instead, you'll only see the presenters this evening. Second, our presenters will answer the questions many of you have submitted in advance. If you have a question during the session, please use the Q&A feature on the bar at the bottom of your Zoom screen at any time. The chat feature is turned off for this presentation. Our experts will answer your question after each of the three have made some individual remarks. Okay, so the panel. Today we have three of my esteemed colleagues from the fields of disease ecology and evolutionary biology and genetics here at the University of Montana to give you their perspectives on the COVID-19 pandemic. Though these folks are expert researchers, we ask that you please keep in mind they are faculty scientists and not licensed medical practitioners. They will therefore not be providing any medical advice or recommendations. We will begin with Angie Lewis. Angela Lewis received her PhD in ecology at Penn State University in 2010 and did postdoctoral work at Colorado State University and Princeton University before joining University of Montana faculty in 2014, where she is now an assistant professor. Angie is an infectious disease ecologist in the Department of Ecosystems and Conservation Sciences and the Wildlife Biology program. She studies how diseases spread through populations, what leads to outbreaks, and how to control them. Most of her research is on diseases in wildlife, particularly those that can spill over into humans, such as hantavirus. Angie, thanks for joining us today. We look forward to hearing your remarks.
Thank you. So let me just get this shared. Okay. So I'm going to first give you an overview of how epidemics spread, how we control them, and where we are now in Montana. Then Dr. Brandon Cooper is going to take over and tell you a bit more about the uncertainties and what's to come. So when we study how viruses spread through populations, we group people into different classes or categories. A person is either susceptible, so uninfected but can get infected, or they're infected and infectious, so contagious and can spread the infection to others, or they're recovered and immune. So they've had the infection, they've recovered from it, and they're no longer contagious, and they can't get it again. And so over the course of an epidemic, people move through these different categories. At first, everyone is susceptible before an infection comes in. And then an infected person can come in and interact with these susceptible people, like cough on them, for example, and get them sick. So then they leave the susceptible class and they move into the infected class. And so while they're there as long as they're contagious. And then eventually they either die or they recover. And when they recover, they're now immune. They're not contagious anymore. They're immune and they can't get infected again. And so we as epidemiologists track how these different classes of individuals changes over time. And so first, let's look at the infected class and how the number of infected people changes over time. So when an infection comes into a population, it starts to spread person to person. It looks really slow here in the beginning, and then it starts to shoot up. And the rate at which this is growing, so this is what we call exponential growth, and the rate at which this is growing is determined by this quantity we call R naught. So that's R with a sub-zero, so not as in N-O-U-G-H-T, as in nothing. And what that is the average number of people that each infected person infects. And this only applies to the early stages of an epidemic. That zero actually stands for time zero, like right in the beginning of an outbreak. And so I'll explain why that is in a minute. But so for example, if R naught is equal to 2, this means that an infected person comes into a population and they cough on and infect 2 others. And then those 2 people go on to infect 2 others. And those all infect 2 others. And so you can see this could balloon out really fast. So this is what we call exponential growth. So here in the beginning, we've got 1 infected person, and by about 5 weeks later, we now have 32 cases. If R naught had been 3, then each infected person would be going on to infect 3 others, and those 3 others. And you could see that that would make a really big difference in the spread. And so here's a difference, here's to show you how much of a difference an R naught of 2 versus 3 makes. So these are both growing exponentially, but the R naught of 3 shoots up much faster. It has a much faster rate of growth. So R naught is really key to describing how fast an epidemic is going to spread in the beginning stages. So if we watch how the infection is spreading over time, it looks slow in the beginning, then it shoots up, and then it starts to slow down and level off and then drops off after that. And this happens naturally, even if we do nothing. And so why is that? That's because as the number of infected people is increasing, the number of susceptible people is decreasing because people are leaving the susceptible class to move into the infected class and then eventually into the recovered class. And so that means that the number of susceptible people, there just aren't as many susceptibles around left to infect. And so the rate of growth slows down. So for example, if an R naught was 2 in the beginning, where everyone is susceptible, if I cough on 2 people, I'm going to get them both sick. But here in this stage, I might cough on 2 people, but one of them has already been infected. And so they're not going to get sick. And so after the beginning stages of the epidemic, we call that quantity, instead of R naught, we call it R or RT or RE sometimes, but we drop that 0 off because we're not talking about the beginning of an epidemic anymore. But during this phase of the epidemic, while things are still growing, the number that each one is infecting is more than one. Everyone is infecting at least more than one other. And so our cases are going to continue to increase. Here at the peak, each person is infecting about one other on average. And then after that, they're infecting less than one. And that's because the susceptible pool has dropped way down and there just aren't as many susceptibles left to infect. So if we watch how the recovered class changes over time, what we see is it ends up sort of being a cumulative case count, where the red is the number of infected people. That's how many infected people there are at any one time. Whereas the recovered class is kind of tracking everyone who's been susceptible and moved into the infected class and then the recovered class. And so this is a cumulative case count basically over time that lags behind by about how long the infectious period is. So exactly how many people are infected and the shape of this curve is determined by R naught. So how fast the epidemic spreads, how many people get infected in the end is determined by R naught. So if we had an R naught of 4, it's going to spread through a population really fast. It's going to burn through those susceptibles and the outbreak is going to be over in a shorter amount of time, but it's going to be a large outbreak. If we decrease R naught, we see that the peak number of cases declines, but the outbreaks are also taking longer if we decrease R naught. So the peak number of cases is lower, but also the total outbreak size, how many people are infected by the end. And so that's given here. So if an R naught of 4, by the end of the outbreak, we would have 98% of the population that ends up infected. With an R naught of 2, we would have about 80% of the population that gets infected. So when you hear the phrase flatten the curve, that's what this means. That means reducing R naught. So when thinking about public health strategies, you might have several end goals. One goal would be to reduce R naught below 1. If everybody's infecting less than one other, then basically we won't have an outbreak. We'll just have 1 or 2 cases and that'll be it. And so you would have just a flat line, which would be ideal. If that's not really tractable, then another strategy might be to try to keep your number of cases below whatever the capacity of your healthcare system is. So for example, if this is the capacity of your healthcare system as far as ventilators and doctors and hospital beds, then if you get above that line, then you're really in trouble. You're going to have a much higher mortality rate up here. And so one public health strategy might be to reduce R naught enough just so that it stays below your peak cases stay below what that capacity is. So this strategy isn't reducing R naught below 1. So you're going to end up still with a large number of cases and a number of deaths. And this capacity of hospitals is going to depend on different communities. There might be communities where there's a large capacity and there might be other communities where there's a smaller capacity. So the goal of public health officials is to reduce R naught. So again, that's the average number of people that each infected person infects. So what determines that? So R naught is equal to the contact rate between different people times the probability of transmission given contact. not every time you come into contact with a sick person do you end up getting sick. So we have to account for that. And then you multiply that by the infectious period. So that's basically how long an infected person is contagious. And so if you want to reduce R naught, you need to reduce one of these three things or all of them. So the infectious period, there for some other diseases, we have some effective drug treatments, like for example, Tamiflu is really effective in controlling viral replication in the flu if you take it early. And so then that can help sick people recover faster, reduce viral replication, shorten the time in which they're contagious. And that could be really helpful. Unfortunately, we don't have anything like that right now for this disease. So there's some things that are going through drug trials, but there's nothing right now that we can do on that end. The probability of transmission given contact, we can affect with masks and hand washing. The most important sort of tools that we have in our toolbox are affecting the contact rates. So we often do this in stages. So the first thing you would do when you have an infection is isolate sick people. So get them away from healthy people so that they're not spreading the infection. That's the first thing you would do. Then you might quarantine anyone who's had contacts with sick people just to keep them away in case they become contagious before they're showing symptoms. Then you might close schools. So for a lot of diseases, we know that transmission in schools is really important. For this disease, we're not actually sure how important transmission in schools is. Then you can go to banning public events or events of certain sizes. You can have more strict social distancing. And then the sort of the big guns is really just kind of stopping everything, all non-essential businesses, make everyone stay at home. So with all of these measures, the earlier they're put into place, the larger impact they're going to have because of that exponential growth. If you wait 1 week or 2, it will have much less of an impact than if you do it earlier. So here's what the outbreak might look like for the state of Montana with our population size of about 1 million people. So this is using my rough estimate of an R naught of 3 here in Montana and assuming about a 15% detection rate. So there's a lot of uncertainty here. Some of my colleagues have estimated that R naught's closer to 2 here in Montana. We really don't have a good idea of what detection is, but this is sort of on the range of what might be realistic. So here's how infection might spread through Montana. It might take a whole about 6 months for the infection to stop if we did nothing. And here's how many cases we would have total, but we would only be detecting a fraction of those cases, about 15% of them. And what that would lead to would be about 94% of the population that would be infected by the end and around 2,600 deaths. And that's assuming we're not like exceeding that hospital capacity, which you definitely would be in some areas if this scenario happened. So this is what would happen if we weren't doing anything to reduce R naught. But we're working really hard to reduce R naught. So what's happened so far here in Montana? So I'm going to show you what's happened so far in Montana, but this is going to look really different for every state. Some states have larger populations, different restrictions, both in the timing and the severity of those restrictions. But here's what our number of cases looked like. So these black dots are what the data look like up to the governor issuing a stay-at-home order on March 28th. And so the red line is a fit to one of those models, an SIR model, where the R naught was equal to 3. So it's a pretty decent fit. That R naught was pretty close to 3 at this time before the stay-at-home order. And then there was the stay-at-home order. And so what effect did that have? Well, it really brought cases down. And so I fit a model to that part of the curve and estimated that R naught was brought down to about 0.42. So we did a really great job of bringing the cases down. So if we had brought it just below 1, the cases would have declined, but would have been a much slower decline as it was coming down. So we reduced transmission by about 7 times during that stay-at-home order. And so restrictions have started to lift now. And so what's going to happen now? This is something that Brandon's going to talk about a bit more in a few minutes. But I've estimated that if we return to normal, so if we just go back to normal, our normal behavior, because I've estimated that there's about 99.9% of the population that's still susceptible because we did such a great job of bringing these cases under control, it means that R naught's going to return to 3, and the case, we're just going to have that initial scenario right over again, where we could get that really large outbreak with 94% of the population getting infected and more than 2,600 deaths. So, but we're not returning to normal. This is for here in Montana. It's not a complete lifting of restrictions. It's a phased response. And so what effect is that going to have? So the best case scenario would be we try to keep R below 1. So until there's a vaccine available. So these restrictions don't have to be as tough as that stay-at-home order, because we reduced R naught to about 0.4 when we originally just need to get it below 1 now that we have cases really low. And so that means that we need to reduce contacts by about 1/3 of normal, or maybe a little bit higher than that, but also be really strict about hand washing and mask use at any time you're in public. If that's not really feasible, then we could try to keep that R below what our healthcare capacity is. But again, that's going to be highly dependent on your community and what the resources are like there, how many hospital beds and doctors that you have available. Okay, so that's a really broad overview of where we are now using Montana as a case study. Brandon's going to now take over and tell us a bit more about the uncertainties and where we are on the broader scale.
Super. Thanks, Angie. So next, as you mentioned, is Dr. Brandon Cooper. Dr. Cooper received a PhD in, you sharing your screen, Brandon?
Yep.
Okay. It got in the way of my script. Okay, Dr. Cooper received a PhD in evolution, ecology, and behavior with a minor in genetics from Indiana University in Bloomington. He was then a National Institutes of Health postdoctoral fellow at the University of California, Davis. Since starting as assistant professor of biology at the University of Montana in 2016, he has been awarded a $1.8 million grant or $1.8 million outstanding investigator award from the NIH to carry out his research on the spread of endosymbiotic bacteria through host populations. Professor Cooper's laboratory includes several undergraduate and graduate students, technicians, and postdoctoral fellows, all focused on understanding how microbes interact with their hosts. Brandon, take it away.
Okay. Sorry, now it's not letting me. Give me a second.
Wonders of technology.
Let's see. There it is. Luckily, I've had enough experience with teaching in Zoom that I can navigate these things now. We shall see. All right, good. Okay, thanks, Justin. Thanks, Angie. I'm gonna launch off of where Angie was and show some similar data in a slightly different way, but also sort of focus on uncertainty moving forward, the new normal, and those sorts of things that I think many of us are thinking about right now. I think the big question is, what does the future hold? We're wondering, how long these sorts of stay-at-home orders are going to be in place. Many of those are coming up, what the consequences of those are they going to happen again, et cetera. And Professor Lewis and I gave talks at the Montana Natural History Center about a month ago, and those talks are available. I mention that because there you can access those videos which cover some things related to this. But briefly to summarize that, we covered questions about the uncertainty, including when can we lessen social distancing? That varies by place. We're seeing that everywhere now, but to do it well, you generally should be doing it when the gating requirements, we call them, are met. And those are things like seeing decreases in infections for a period of greater than 14 days and having hospitals not overrun, et cetera. And I'll talk a little bit later about how some places are doing that well and others are not. Questions about what will happen when we start to get active, as Angie mentioned. Cases will increase. It's just the question is when and how much. Why is testing so important? Well, we need to catch those cases to stop spread early, and I'll talk more about that here. Why can't we open everything up back now? I think Angie did a great job of showing why we can't do that. We'll clearly overwhelm the healthcare system, even in a rural state like Montana, with an R0 equals 3 and unmitigated spread, given the population is still totally susceptible or almost totally susceptible. We also talked about, is this event surprising? So when we beat COVID, are we done? And I think the answer is no. People, scientists that work on this and others aren't super surprised. And one of the reasons we talked about in the other talks is because there's so many coronaviruses alone in bats. So we know of about 500, we think there are up to 5,000, and that's just coronaviruses in bats. So if you think about other viruses and other pathogens, I think we need to be thinking forward that these things are possible, and it's just a matter of, are we going to be prepared for them? And then we talked about that. How can we be prepared? So more research, infrastructure, and those sorts of things. So there is some overlapping material here, and I wanted to mention this as we open so that you know that those videos are available. And if you want more information on these topics, you could go there. But today I thought it'd be fun to say, so where are we now? What do things look like in the last month? What are things looking like for the future? So here what I'm showing you are some data on COVID cases in the US. And I have a line superimposed here for what the status was on April 24th, the last time we talked about these things. On the x-axis, you have the days since there were first 20 cases. And on the y-axis, you have the new daily confirmed cases. And at the time of our last talk, there were social distancing measures had been in place for a while. That's why you see this flattening of the curve here. And since then, in about the last month, what we've seen is this plateau has sort of continued, decreased a little bit, and now we're kind of wondering what's going to happen as we begin to increase. Remember, this is at the US level, and as Angie hit on, it's going to vary a lot geographically, the way that we experience the spread of COVID. So just to show you that, let me show you the same data broken up by state. So here we have geographic variation in spread, and I want to show you, why I don't think, or many don't think, a one-size-fits-all approach is going to work. So what we have here again on the x-axis is that days since 20 cases. On the y-axis, we also have newly daily confirmed cases, although here I'm showing you a log scale. So just notice that goes 10, 100, 1,000, 10,000, et cetera. And what you can see is that if you're in Montana and you have very few cases and you've essentially really flattened the curve, you're experiencing this a lot differently than, say, in a place like New York, where you were approaching 10,000 cases per day and you still have many cases per day. So you can imagine that what we might want to do in Montana would be different than what you might do if you were making those decisions or advising or planning for the future in other areas like New York or Michigan or other places that have been hit pretty hard. So I'm going to show you that this is the same sort of data. It's the same data that Professor Lewis was showing you, but shown in a slightly different way. So what we see here is that we were really hitting that R0 equals 3, like Angie showed. But what happened in Montana is that the governor put a stay-at-home order in place quite early. So you've probably heard a lot about exponential growth. And maybe you've heard people like me and others say that, anytime you're making a good decision, it's going to maybe feel quite silly, because making a stay-at-home order when you don't have many cases, that seems pretty surprising. But this shows how that works. So when they put that in place, there were only 15 cases per day. You can see that spread almost instantly went down. And it didn't just flatten the curve, it took it down to essentially 0 cases, right? So this is a real example of what you would hope for when you say we want to flatten the curve. This is what you want to see. The stay-at-home order was then lifted. And again, the stay-at-home order was lifted in line with public health recommendations, which include waiting at least 14 days to lift that. That's because there's this period of time that you need to, for cases to develop, to be caught, and all that sort of stuff. So you need to wait to make sure that it's really going down, and that was done. So it was lifted. And then what we've seen since then is not much going on. It went down to essentially 0 active cases, and then a few here in the last few days. So you've probably heard, if you're in Montana at least, or if you're in other places, I'm sure you're hearing about places opening up and potentially moving to the second phase of opening up. We're doing that here on June 1st in the state of Montana. What does that mean? Well, that means that gatherings are going to expand to 50 people. That's going to now be okay. They're still going to recommend that vulnerable populations with pre-existing conditions avoid as much activity as they have been. Gyms and pools and hot tubs and other things that were deemed non-essential originally are going to open. And in addition, into houses of worship, other places can open up with these group sizes. So what we're going to really see is more activity. So as Professor Lewis was talking about, we still need to reduce our activity. The question is when we do this, what's that going to do to R naught? Are we going to see that increase again? So we have this little bit of time here where we can watch the data and see what's going on before June 1st, right? We really hope cases remain low here prior to phase 2. Any sign of them increasing would be worrisome to enact that. I suspect they're probably going to remain low, but what we really want to know and what we really need to pay attention to is what's going to happen following phase 2. Because remember, as Angie said, the vast majority of the population is susceptible. In many ways, we're sitting with a population that's not so different when COVID first came here. So we fully expect that when cases get here, if they go unmitigated, they're going to spread probably at something like R naught equals 3, given what the data suggests, as Angie showed. So then the question really is are we going to catch those cases in time, be able to trace them, et cetera, which I'll talk about here in a second. But to give you a little idea about the geographic variation, and this is just, I almost randomly chose Texas. There are many other places where we could show that are different from Montana, but I think Texas is a particularly interesting one here. You can see that, and this is the same plot, just to be clear, the x-axis is still the days since 20 cases, and on the y-axis here, it's no longer logged, you just have the new daily confirmed cases. And what you can see is that there was a real exponential increase there. Right? And you had a similar stay-at-home order put in place. It seems like from looking at these data that it was obviously effective and that it did flatten the curve, but it's not like what we saw in Montana where you put that in place and then cases went back down to 0. And then you see the stay-at-home order was lifted, and subsequently you see cases starting to rise again. So what are the sort of differences here? Well, there are a couple. Here, whenever the stay-at-home order was put in place, you had greater than 500 cases per day. So when Angie said it really matters about catching these early when you're dealing with exponential growth, here relative to Montana, you had 500 cases per day when this was put in place versus 15 cases per day. So you were farther along on that exponential increase when that happened. The other thing that happened is that the stay-at-home order seems to have been lifted when you haven't had an obvious period of time of decline in cases, right? There wasn't this 2 to 3 week decline in cases kind of up and down through that period. And so what that means is you've still got, presumably, you've got COVID circulating in the community, and then you lift that, you get more activity, and they start increasing sort of straight away, right? So a little bit different than what we saw here. Back to thinking about R naught, if we look at state level variation in R naught, these are data from mid-April. So this is well after there had been social distancing measures put in place. And each of these little bubbles are just different states. I put that line there, the dark horizontal line is R naught equals 1. And so this is to show you that in mid-April, after distancing measures were put in place, you had a lot of states still above 1. But they were all hovering around 1, right? You don't see that they were at that high level that that Angie showed at the early stages of spread in Montana and other places. And that's in line with what I showed you and what you've seen with that sort of plateauing of the curve here. Montana and all of these, about any way you look at the data, is particularly well suited with fewer cases than other places. So that was mid-April. If we fast forward to today, maybe this was yesterday, what you can see is that almost everywhere is under 1. These lines that you see are the sort of clouds surrounding those bubbles. Those are, you can think about just our confidence in the estimates. So it's possible that one of these that's under 1, the actual value is over 1. But the point is that they're all hovering around 1. They seem to be lower. But there is variation in these, right? And there's also variation in the total cases among states, et cetera. And I mention this because I think it's important to know, we often think I can tell the success story of Montana, but I think it's important to know that we're also highly interconnected, that I think we need to be really concerned about our local communities, but we need to be hopeful and proactive about encouraging responses everywhere because we're also interconnected. So I'm just showing you a picture of the average flights on any given day in this country prior to COVID, and presumably That'll be that way again sometime soon, but it just shows you, I mean, these are people moving around, right? So now imagine you have an ongoing epidemic. You're doing great locally, but every day you're getting this influx of new people, right? I think for a place like Montana, just to make that point more clear, is that great, we have this good situation going on locally, but once we open back up, you already see Yellowstone is opening up. I'm guessing we'll have more things coming in soon, business travel, returning students, et cetera. We need to just be thinking that there's going to be COVID cases come to Montana. So what do we do? Well, you hear all about testing. You're probably hearing these insane numbers of tests we need to do. Well, they're not insane. We got to be doing that level of testing to catch these things that are out there early and often. You can really think about these as a little fire that's sitting out there. If you stop it, sure, you just stomp it out. If you don't catch it, it quickly turns into a massive fire that disrupts life for everyone, right? So the way we catch those is we do these PCR-based tests. I won't get into that, but just a test that you could do in my lab quite easily. We do them most days in the lab. And that tells you if someone is currently infected. Now, we know that people are passing on COVID when they're asymptomatic. It turns out they're passing it on really well when they're asymptomatic. So when you first get symptoms and come in and then you get a positive test, we know that anyone you've come into contact with in the recent past, there's a high probability that you could have transmitted the virus to them, right? So great, we've tested, that's important. So then you probably are hearing that we need to trace, right? So we need to know who you've interacted with, right? There's another kind of testing that we can maybe talk about in questions that I'm not going to touch on a lot. And those are, you've heard about antibody testing. That's going to be a good way to tell us the proportion of the population that's been infected. That's really important for knowing how many susceptible individuals you have. It doesn't at least seem like it's going to be useful right now for, say, finding out that you've been infected and then using that to say, oh, great, I can become more active in the community than other people. The reason that is because there's a lot of false positives and false negatives. And also we don't really deeply understand at least immunity as it pertains to being infected, which I suspect we'll talk about more too. So why do we need to trace? I mean, other than obviously you want to know who's infected and who that they have come into contact with. Well, the reason is, let me give you one example from this month in Seoul, South Korea. In South Korea, who's done particularly well in dealing with COVID-19 spread. You had one infected, and this has been traced to one infected 29-year-old club goer. So this is just individuals that are going out to clubs at night. So one individual was the source of 170 new infections, right? That's pretty scary that you can have one person turn into 170 more, but that's the best part of this story, I think. The worst part is that they ended up having to test 65,000 people, at least the last article I looked at. You look at it, was 35,000 the other day. The most recent local article I read was 65,000. So just imagine the amount of infrastructure, the amount of legwork, what you have to do this tracing. So when you hear people say we need to ramp up testing, we need to ramp up tracing, this is really what they mean, right? You have to have that in place because once people start coming in and you get infections starting to spread, if you don't catch them, it can become a big problem, and to catch them requires work. So just a summary of this brief talk is, I think until we have a vaccine, the new normal is that any increase in activity is somewhat risky, and without adequate testing and tracing, it's going to lead to more infections. There's no doubt that as we become more active, there will be more infections. The question is what measures are we going to put in place, and are they going to be sufficient to make those new cases not turn into full-blown outbreaks in your local area? So just some closing thoughts. Montana looks better than about any other state, any way you look at the data right now. Increased activity locally will lead to more cases. We're particularly worried about close contact indoors without masks, which is a particular concern, especially in a society like the US, where we're quite independent and don't want to be told to do those things that we should too. Travel into Montana is going to lead to more cases, all else equal, I think, because everywhere people are coming from, on average, has a higher prevalence of COVID than we do. Lots of testing is required to identify infections and to trace their contacts. It's going to require a lot of legwork. And then I think fortunately, locally here, we're quite lucky that our local leaders have really been using science to inform public policy and really engaged from the beginning to really flatten that curve and make these decisions that have been useful. I think particularly the focus locally at the university level and everything needs to be on mitigating this, testing, tracing, and isolating. And I think with that, Doug is going to maybe launch off into some of the ways we're thinking about doing that locally here at the university. Thanks.
Thanks.
Super. Thanks, Brandon. That's right. Next, we have Dr. Doug Emlen. Doug Emlen studied at Cornell University, Princeton University, and Duke University before joining the faculty at the University of Montana, where he is a full professor. He is an elected member of the American Academy of Arts and Sciences and a recipient of the U.S. Presidential Early Career Award in Science and Engineering. His book, Animal Weapons, The Evolution of Battle, won the Phi Beta Kappa Science Book of the Year Award in 2015. And his textbook, Evolution, Making Sense of Life, co-authored with award-winning journalist Carl Zimmer, is presently adopted by more than 250 universities and colleges. His first narrative nonfiction book for middle school readers, Beetle Battles, One Scientist's Journey of Adventure and Discovery, appeared on shelves this past December. Doug, welcome, and excited to have you on the panel as well.
Thanks. I think I should have done a shorter bio. Sorry about that.
Okay.
And I don't have any, full disclosure, I don't have any slides. I'm going to give most of my time to the discussion because I think there's going to be a lot of questions that people have. But what I do want to say briefly is that I'm an evolutionary biologist. I take a slightly different perspective on some of these questions than Angie, for example, and Brandon did in their talks. And I think all of you got a link to a lecture that I give in one of my classes where I sort of take the evolutionary biologist framework to look at the world from the perspective of the virus. And in that case, dig into what happened in the influenza pandemic in 1918. So I'm not an expert in coronavirus, but I do have a perspective that is relevant. But what I really kind of wanted to talk about for a minute or two, to be honest, is just how impressed I've been as a scientist with the way this administration and this university has tackled this. I mean, I think Angie and Brandon can attest, we've all got colleagues all over the country that have areas of expertise that overlap with this problem in one way or another. And to the extent that I've been able to ask around and check in with my colleagues, we're the only ones I know anywhere where we've been actively folded into the fray and sort of welcomed into the decision-making process. And that's been awesome. It meant that we got to sort of break away from our daily routine and throw ourselves into the middle of all of these rapid, high-stakes decision-making processes, and we get to sort of see the sausage being made, so to speak. And it's been awesome. I've been so proud to be part of this institution. So as a scientist, we've been able to sort of weigh in and bring some of the data and bring some of the models to the table and help clear some things up. But really what we've been able to do is just contribute to a team of dedicated people that have been sort of racing against the clock. First of all, early on, figuring out how are we going to protect students with this thing looming on the horizon. I think was really proactive and really fast in making the decisions to go remote. At the time, it was an unpopular decision, but I think if you look back now, everybody would agree it was the right decision. It meant that students had to scramble, faculty had to scramble, all of the staff and administrative, everybody had to sort of learn how to do things differently, just like that, in order to flip to remote and have everybody stay dispersed quick enough. It was I didn't even know what Zoom was 2 months ago, and now I'm using it for multiple hours a day. It was a momentous change for an institution to do. And every college around the country is having to go through some iteration of this, but it's been awe-inspiring to watch this process. And now they're re-engaging to try to figure out, okay, how do, this is the last best place. We've done very well so far. The cases are way lower here than elsewhere. We've got lots of open spaces. There's kind of no better place to socially distance. How do we bring students back? It's a tough challenge. As Brandon pointed out, you can't win, right? I mean, the reason we're great here is because there's nobody here. As soon as all the out-of-state tourists come in, we know they will do this summer, we need them to. The economy of the state hinges on the tourism business, but all those tourists are coming from other parts of the country that have much higher prevalence of the virus. So we're essentially guaranteed to see an uptick in cases. And then all of the students coming back, particularly the out-of-state students, are all going to come back. How do you do that, right? I mean, I just think it's worth thinking for a minute about all the balls in the air and what you have to do. You're dealing with a young adult, by and large, not all students, but a large population of relatively young individuals for whom this disease isn't actually all that dangerous statistically. So they tend to be of an age group where you think you're invincible. And statistically, this isn't likely to be that dangerous for them. So how do you take a population of students and help shift the culture so that we train them along with everybody to be socially responsible, so that we make decisions that protect our own? Because it's not really the students, it's the staff and the faculty. We've got a lot of people on campus who are now going to come into contact with lots of students from all over the country, and we have to protect those people too. So there are all kinds of challenges, but there's also all kinds of opportunities. There's things you can do on a campus to try to help contact trace, like taking attendance at every class and requiring assigned seatings in classes, where we can do a faster job back tracing who had contact with who on a university campus than you might be able to do in a city or in a more urban environment or community. So there's also opportunities. So I just want to say quickly, I'm part of a task force that the president and the administration put together that is very aggressively tackling these challenges. And it's an amazing group. It's got people from St. Patrick's Hospital, people from our Curry Health Center, people from the public health department, epidemiologists, biologists like me, people from athletics, people from the dormitories, people from the dining halls. I mean, all the rec center, all the people that are sort of responsible for protecting the health and the safety of this community are all sort of in this discussion together, figuring out how can we do this? What do we need to do to make it right? And the attitude from the start has been, bring it on. Any options are welcome. We take any suggestions. Let's figure out the best way forward and make it happen. So it's been a rather awe-inspiring process to watch. I will say that Brandon touched on in his last slide, that task group is sort of subdivided around 4 key tasks. And I think it's worth mentioning those now. One of them is going to be testing. We're going to have to ramp up the capacity to test on site quickly. And it's something that, you know, we've been able to do maybe dozens to a couple hundred at most per day. We're going to have to potentially do thousands per day. So how do you take the infrastructure? How do we plan in advance to make sure we have the reagents, we've got the equipment, we've got the personnel, you know, all the steps that we need to do to be ready to go. There's a group that is tasked with isolation and quarantine. So operating under the assumption that at least one of these people coming back is going to test positive, what do you do? How do we isolate them? And then we've got a group that's specifically focused on contact tracing. How do we use the technologies like Grizz cards or operational opportunities like taking attendance in classrooms? What do we do to try to make sure that we can work with the county health department? There are county health department people on this task force too, to very, very quickly and accurately backtrace from any person who tests positive, so that within our local community, we can quickly spiral out and test the related people and potentially isolate people that were exposed. And then there's a group tasked with the physical isolation of quarantine. Like, do we need to lease a hotel? Are we going to have whole dormitory buildings that we keep separate so that we can isolate people? There's a lot of moving. And then the last one is mitigation. How do we make the facilities themselves as safe as possible? Is it plastic shields? Is it getting tons of masks? Is it physically separating chairs within rooms so that we force the separation, the physical distancing? Or are there things we can do to encourage classes to be taught outdoors? There's all kinds of things that are sort of being discussed at 90 miles an hour, but I'm pretty confident that this university is going to be ahead of the curve again, and they're going to be positioned well by the time we bring our students back. So.
Awesome. Thanks, Doug. Well, unfortunately, we have way more questions than time, but that's a good sign. We'll get through as many as we can. A question that maybe you can take, Angie, is a question about the origins of the virus. There's all this talk about it coming from bats. What does that mean? What do we know about the origins of this virus?
Yeah, we're pretty sure that this spilled over from a bat. There are very closely related coronaviruses that have spilled over from bats in the past. There was an outbreak in 2001 called SARS. And then there's been an ongoing MERS outbreak over the last 10 years or so in the Middle East that spilled over from bats. It's a very closely related virus there. So, and we've traced the beginnings of this outbreak to a wet market in China. We're not sure if there was an intermediate host that, so with SARS, the outbreak also started in a wet market. But we think that it spilled over from a bat into civet cats, and then from civet cats to humans in the wet market. And so often there's an intermediate host between the bat and the human, We're not sure if that's the case here. We haven't identified an intermediate host, but there might be something that was in the wet market and it might not have come directly from bats. But there's pretty good evidence that it did spill over from bats.
Super. Question that maybe Brandon can take. What are some of the key lessons learned from other pandemics, the 1918 flu, the swine flu, bird flu, SARS, et cetera? And within that, what follow-up lessons do you fear that we might not be learning from?
Yeah, so I think the lessons have been, so there's lots of, and Doug can speak on this too, but there's good evidence that different strategies that were employed in different places really mattered. So for example, if you had a parade or you didn't have a parade on a particular holiday, really explained a lot of different. So we knew that social distancing and things like that could be really useful. I guess I worry about a lot of things. In the 1940s, there were 35,000 people crippled by polio yearly, leading parents to not let their kids play outdoors, et cetera, until a vaccine was introduced. Yet we all know that there is a substantial part of the population that's not receptive to vaccines, despite knowing these things. So I think I worry that we forget about history. I worry about misinformation and people maybe not trusting things that I think should be trusted. So I find myself wondering, well, we have a vaccine tomorrow. Do we need to worry about people being receptive to that, those sorts of things? But yeah, lots of lessons to learn. And I think those lessons are that you need to mitigate these things, you need to test, you need to trace, and when you find them, you need to isolate. Those are the things we know. It works when you can do it. And I think that's what we need to focus on here.
Yeah, so a question came in just now from the live audience, and it certainly resonates with me because it's something I think about often. With your expertise, are high-risk elderly individuals safe to see small amounts of family? If that family has been most entirely at home, do you think getting tested beforehand is possible, or is it an overreaction? Yeah, what are your thoughts on trying to visit relatives?
Who wants to do it?
Well, I would just say, yeah, it's really hard. I'm not going to give advice to anyone on this sort of thing. Part of me wants to say there's no better time but now, because we could predict that there's going to be more cases in Montana and most other places as we begin to open up. But it's also absolutely true that you could be meeting with someone who's been around their high school age kid who hasn't been careful and they're not showing symptoms, but yet they're transmitting. So it's a risk. I see it the same way as deciding to go out and drive, and whether you wear a seatbelt or whether you go on the interstate or not, they're risks. It's absolutely more risky than not doing it. Yeah.
Fair enough. Couple questions came in early on.
Justin, I just want to weigh in one other thing, because I mean, this is something a lot of families are struggling with. And again, we're not medical professionals, so don't take this as law, but I think that there's some extra steps you can take if you really feel like you want to have your family in person. I mean, I really think that the elderly people, if they can get their hands on them, should be wearing the N95 level masks, hopefully with training, so they're wearing them properly, but that really would protect them from inhaling things that their family members might be bringing. But at the very least, the family members should be wearing masks when they're inside, when they're in the contact space with these people. And you can do a lot to wipe down counters and sanitize hands and really sort of minimize the risk of those exposures. But there's no way around it, that when you bring people, families or others from the outside in, you are putting these people at risk.
I would just say one other thing I would say is that you absolutely can interact from a distance, right? I mean, I have elderly neighbors who have been interacting with their friends for much of this. We interact a lot, but they come in through their backyard on a nice day and they all sit 6 feet apart and have a really nice time. So I think there are compromises and obviously strategies like wearing masks, but it's particularly risky to just have a bunch of people inside your house on a rainy day, yeah.
No, that's it. Actually, do it outside. Don't even bring them into the house. That's way better. Sorry. Go back to your next question. Sorry.
Oh, super. No, great stuff. Question kind of came in during Angie's remarks earlier. Two people asked about reinfection. What do we know about reinfection Is that a thing? How likely is it, etc.?
I'll take a stab at it, and then Brandon can maybe jump in. We honestly don't know a ton yet, but the evidence is pointing towards, so we do form antibodies and they should be protective. There have been a few cases documented of reinfection, but we actually, when we go back and look at a lot of those, we think that maybe they actually weren't true infections in the beginning, like they could have been false positive tests. Or if we're looking at antibody tests to look at previous infection, often that has a higher false positive rate as well with the tests. And so a lot of the people that are talking about reinfection, some of that data is a bit questionable, at least that's my opinion. And so I think I'm pretty optimistic that we will get immune after being infected or with a good vaccine. So that's, but we honestly just don't really know yet. Do you want to jump in with that, Brandon?
Yeah, no, I completely agree with that. I don't think we know yet. I think the cases that have seemed like reinfections are often suspect. There is some new data coming out that suggests that I think in the positive direction here. I guess what I would say is I think when we look back a few years from now, we'll see that there was protective immunity. I think the timing of how long that lasts is not known, but cautiously optimistic is what I would say I am. Yeah.
Can I add a 2 cents on this too? Are we okay on time? I mean, I think it's important for people to recognize that, as of December, we didn't even know this thing existed. So there's been a very short time window for people to learn about what's going on. And I think that people have been learning things at a spectacular rate. I mean, it's a real time for shout out to scientists and what they've been able to do fast. So there's a lot about how our immune systems are interacting with this virus that we just don't know yet, and it just takes time. But there's another way. The other reason that immunity would sort of fall apart over time is if the virus itself is evolving so rapidly that if your body builds an active protective immune response to the virus when you caught it, a year later, the virus might have evolved so much that it's molecularly so different that it's unrecognizable to your immune system, and that's how you could get it again. And that's what's going on with influenza, for example. That's the reason they have to keep remaking the vaccine, is that the virus is evolving so fast that it literally is a moving target, and your immunity you still become immune. It's just, it doesn't last that long because the virus keeps evolving. The evidence to date suggests that this virus is not evolving that fast. The genome of this virus is not accumulating new mutations as rapidly as things like HIV or influenza. So far, I concur with these guys. I think it looks, from a biological standpoint, pretty good. Like, you ought to be immune for at least a couple of years, and that ought to work. But obviously, we still have a lot to learn about the details of the virus immune system interactions, and none of us are going to be confident in this until we know more, and it's going to take more than 3 months for us to learn that.
So we hear a lot about this 6-foot guideline. Is that something that's just a public health guideline for most infectious diseases, or is it specific to COVID-19? Where does 6 feet come from?
Who wants it?
I say Doug takes this one.
I'm probably the least qualified. I think, all right, I'm going to take a stab at this, qualifying that I'm not a coronavirus expert, so you guys correct me if I'm wrong. But this is not a virus that survives it's not airborne. It's carried in droplets, so like spittle droplets that are spewed out when you cough or sneeze or breathe on people. And those droplets evaporate very quickly, as small ones in particular dissipate and evaporate fast. The bigger ones last a little longer, and they tend to fall. So this is based on some studies that actually looked at and tried to measure and tried to project how far out from a person you have to be before the sort of rate of dissipation and evaporation and fall of the droplets has declined enough that if you are inhaling, you're not likely to inhale enough of the virus to actually get infected. It's a guideline. People need a simple number so that they can put the stickers on the floor, but it's based on models for how far the droplets from a typically breathing person are likely to spread. And it's a guideline, right? Is that okay?
I think that's great. The only thing I will say is, I think some of the data from spread indoors, and I'm forgetting the exact study, the recent one about spread in terms of where people were sitting relative to an infected person in an air conditioning vent, things like that. I don't think we totally can say that it's not airborne, but the data, there may not be good data to say that it is. But I think there's some patterns in the spread indoors, a few different studies that suggest we should be worried about that.
Yeah, the term airborne, like by epidemiologists, is used in a very specific way to mean like super tiny particles that can remain suspended for a long period of time. So you can get transmission through the air with these respiratory droplets because they do last a little bit of time in the air. So these terms get confused by people. And so anyway, it ends up just sort of being definition and semantics, but.
So we got a question about detecting cases and data, et cetera. You know, this notion that one of our listeners has heard that the data tend to be 14 days behind the actual number of cases within a community. Based on our current testing capacity and turnaround time, do you have a comment on the current plans for reopening and the phased reopening? There's a lot in that question, I realize.
Yeah, so it takes so it's just the amount of time it's going to take for someone to have the virus, to show symptoms, to get tested, all these sorts of things. And just like the way you see when you look at cases, if I were to show you graphs of the people that have died from coronavirus, those things have a lag, because sometimes that's not for, say, 30 days or whatever. But basically the main point is that if you open up, you can't, if you open up on Monday, on Friday, you can't say, all right, we did it, right? Because any new transmission that's happened is not, much of that is not going to have been caught yet, just due to the time it takes to show symptoms and things of that nature. The slides I was showing about differences between, say, Montana, the way they reopened and waited, versus Texas reopening when it had sort of plateaued and was going back and forth, down a little bit and up a little bit. Those can lead to quite different outcomes.
So I think we have maybe time for one more question, and I would ask that maybe all three of the panelists comment on this one. Can you, what have you learned about your university in this moment, and how this has affected both faculty, students, and staff? How's the university reacted in your view? Angie, let's start with you.
Sure. I've been really amazed. We all have been through a lot. We had to figure out this whole online transition super fast. So it's been a transition for all of us, but it went way better than I expected it to go, both on my end, figuring things out, but also the students. Like, the students have been amazing. They have been so resilient. And a lot of them have been super participatory in conversations online. And, it's not quite the same as meeting in person, but the students really, really needed the interaction, them being stuck at home too. And so they were really participating in class and found it very engaging. But I was also teaching a class called Ecology of Infectious Diseases at the time. And so it was super appropriate, and it was a great case study. And so we had a lot of great things to talk about. But I've just in general been really amazed by how well everyone has coped with all of this.
Awesome. Doug, your experience.
I'll do two sides. One is, as a professor, I was teaching a class, genetics and evolution, that has 220 students. And so learning how to flip to remote was a momentous sort of experience for me and for the students. But I echo what Angie said, the students were awesome. I was thrilled with the extent to which they worked with me, because there were a lot of mistakes made along the way. And I really feel like it was an amazing learning experience, and I'm very proud of the students. But I also want to say that because of the things I alluded to before, getting swept into the sort of higher level planning let me look at the sort of guts of the decision making, and wow, real leaders rise to the challenge in a crisis. Oh my gosh. So the thing I have to shout out is I've been stunned and amazed. I feel very lucky to be at an institution with the leadership that we have in place right now, because it shows. And I've been amazed at my colleagues from all different parts of campus that basically, as busy and as frantic as they were and as overwhelmed as they were, basically came out of hiding to say, you know what, how can I help? And the number of people that have been putting in crazy hours to help work through the data, work through the ideas, figure out the legal issues, the personnel issues, the safety dormitory. I mean, the number of people that sort of showed up at the table saying, let me help, let's get this done, kind of blew me away. So for me, I come out of this sort of humbled and awed by this institution. And also, I've said this before, I think this is a test run. I think Brandon alluded to it. I think we're all going to see this kind of thing happen again. So we're all sort of learning from this experience. And I think this institution, I don't know, I think we're going to be ready next time too.
Awesome. Brandon.
Yeah, I think I'll mostly echo their comments. As a professor, I was teaching similar to Angie. I was teaching an upper level host microbe interactions class that was focused on reading primary literature and presentations, and it's an intensive writing course. The students are amazing, both in their resilience and just their abilities. So that was great. It was also, this is a terrible thing, but a silver lining as it's teaching that course, like Angie said, it's particularly interesting time to be thinking about how microbes interact with hosts. And so we ended up talking a lot about that towards the end of the semester. And I was just amazed by the students. I continue to be amazed. I've been here since 2016, and every year I'm just amazed at the quality of the students and how engaged they are in this upper level class I teach. And then on the flip side, I'll echo what Doug said. I mean, my involvement in interacting with anything at the university level on this came basically, I think, by sending Doug an email like, hey, are people paying attention to this in February or something? And I think it was like a day later, I got an email that was like, hey, you should come to the meeting. They were instantly like, let's talk to the scientists too. And so, and I'm not an epidemiologist, it was just reading, deeply in the papers and stuff that were coming out. And they instantly were just wanting to know, well, what did the data look like? Really data driven, what are you seeing? And then just the thoughtful way, I think, in which sort of everybody at the tables had a voice. And I've learned a lot too, I mean, this is obviously a complicated thing, but someone like me has never thought about the challenges that you have for, the rec center or the dorms, or how do you, the students that need to stay when you go remote or close down campus, but they need a place to stay. How do you feed them? All that, and seeing people solve that and doing all of this on like extra hours, and many people like some of us here with small kids and trying and partners with full-time careers and stuff like that, and just pulling it together to do that has been a real silver lining for me that I think was a nice distraction in some ways from just being, stuck on reading the news and the new papers that were coming out initially. It was a bit of a whirlwind. So it was a really positive experience for me and left me feeling very happy to be at a university that's data driven and really has a focus on the health of students and staff.
Awesome. Thank you, Brandon. Unfortunately, we're out of time. We got way more questions than we have the time to answer. Maybe we'll figure out a way to address that after the fact, because we've captured a lot of these questions. This session was recorded and will be made available along with some of the other panelists' expert content as well. We thank them for their expertise and sharing their time with us tonight. Please join us next Thursday for an alumni town hall, where the University of Montana President Seth Bodner will be with us, and he will give you an update on the university and answer your questions. On behalf of the University of Montana Alumni Association, thanks for coming tonight. Thanks for your questions, and good night. Take care and go Grizz.
Justin, thanks all of you. Stay safe.
Thanks.